Okay, I think it's recording. All right. Welcome and thank you for joining us today, Dr. Glenn Nielson. Dr. Glenn Nielson is a physiotherapist at the St George's University in London, and we're very grateful to have him here today to discuss physiotherapy for FND and also his randomised controlled trial of physio for functional movement disorders. So welcome, Dr. Glenn. I'll move into the slides. Share screen. Okay, and so we're having a series of interviews with experts for our FND Awareness Day in Australia and the UK on the 25th of March. And we're interested to speak to experts in this area to learn a bit more around how different treatments can help people with FND. So first up, many people with FND, with functional movement disorders, are referred to a physiotherapist. For many people, it's just referred to the local physiotherapist. It may not be a neurological physiotherapist, and it may not be someone who has specialist training in FND. So I'm just wondering, what is the difference between a general physio that might be at the local shopping centre and a specialised neurological physiotherapist?
It's a good question. A neurophysio or a neurological physio is typically someone who's got specialist skills and experience in helping people who have disorders of the central nervous system. Perhaps the most common disorders that a neurophysio would see are things like stroke, Parkinson's disease, and people who have movement problems after a head injury. And they typically have a set of symptoms that can include weakness, spasms or increased muscle tone or spasticity, tremor, dizziness, and problems with sensation. And so a neurophysiotherapist has experience with those sorts of treatment, and really a lot of what they do is aimed at helping restore normal movement, most commonly trying to help people walk again, but other types of movement as well. I should also say, we often say that a neurophysiotherapist might be best placed to treat someone with functional neurological disorder, but they don't necessarily have to be a neurophysio. If they have experience and skills, these sorts of physiotherapy techniques aren't owned by neurophysios. There might be other types of physiotherapists who are equally as good.
Okay. So should people be seeking out a neurophysio, or would a general physio work, or could it cause harm?
I don't think it necessarily can cause harm. I think the most important thing is the physiotherapist understands the diagnosis. And in the UK and probably in Australia, the type of physiotherapist most likely to have come across FND would be a neurophysiotherapist.
Yeah.
There are certain parts of the world where that sort of neurophysiotherapy breakdown doesn't exist, so they might see a physiotherapist in another context. But also, as we know, people with FND have multiple other problems, so they might be seeing a physiotherapist for, say, back pain, and they might not necessarily be a neurophysiotherapist. So when it comes to retraining movement, in most cases, a neurophysiotherapist is the sort of the specialty that's designed to help people with that problem.
Yeah, best placed. Cool. Okay, now you've got this trial, randomised controlled trial, physio for functional movement disorders, and I believe you're about partway through this, and you're recruiting patients.
That's right.
Yep. So recruiting 264 adults, 50% will get the treatment and 50% will go to community physiotherapy. And I noticed like 9 sessions over 3 weeks, so it's intensive but short. So how does this specialised physiotherapy that is done in this program differ from what a person might get in a community physiotherapy session?
So it's a difficult question, and it's really difficult to design a randomized controlled trial. We wanted to compare, and the type of funding we got from our trial usually wants us to compare what's normally given, treatment as usual, to something different. And so we wanted to design something different. We wanted to design a physiotherapy program that was really aimed at and very specific to people with functional disorders. So it's based on, it's sort of like, it is completely grounded in physiotherapy, but I guess it's really designed with a lot of understanding of typical problems people with FND have.
Is a community program, I noticed like this is 9 sessions over 3 weeks. The community physiotherapy, does that have less sessions or is that the same amount?
So this is another thing with the trial. Usual treatment in the UK isn't perfect, much like it isn't in Australia, and it's all a bit different. The complex way in which community rehabilitation is funded in the UK, it's all funded by the NHS. It's available free as part of your tax, but certain areas provide very good comprehensive services, and there are some areas in the UK which are very underfunded and don't have a lot of resources to provide good physiotherapy. So what we'll find when we do the trial is that some of our control group will have a lot of treatment and some of them won't have a lot of treatment. So really, one of the limitations of the trial is we're not comparing to, there'll be some differences in the control group.
Yeah.
But what we're going to show is that we hope to show if you give a very specific and comprehensive treatment program, it's better than what's happening at the moment. But we need to wait and see what the trial results are.
And people who join in the program, is there sort of a duration for how long they might have had symptoms? Like, are you just taking people newly diagnosed, or might they've had it for 7 years or 20 years beforehand?
Yeah, there's no limitation on how long someone's had symptoms for. So previous research might have capped it, so they might have said you've had to have symptoms for less than a certain amount of years. But what we have found, and a lot of our colleagues have found, is that people who've had symptoms for a long time can still improve. Sometimes time is a limiting factor, and it takes people a sort of time to get better. So we don't necessarily think that a long symptom duration is always something that means that the outcome's going to be bad. So we don't limit that at all.
Okay, well, that can give hope to people.
Yeah, and yeah.
Okay, and I noticed in your paper, which is up here, it was talking about the protocol, and it was talking about exclusion criteria. So people that might have, significant pain, significant fatigue, seizures, very, very disabled people disabled from their symptoms, and psychiatric comorbidity are excluded from this trial. So because so many people with FND do experience a lot of these issues, how do you deal with this with your trial? What does that mean for generalization of the trial, and how can we work within these limitations that most people are dealing with?
Yeah, it's a really good question, and it needs a little bit of unpacking.
Yeah.
So firstly, for the trial, the actual wording of the exclusion criteria is something like people who have these symptoms that you've listed there, that would, to such an extent, that would limit their ability to engage with physiotherapy. So, for example, if someone had very, very severe pain and they told us that if they came and did a session of physiotherapy, that their pain would get worse and then they wouldn't be able to come back the next day for more physiotherapy, then obviously this isn't the right treatment for that person. So we wouldn't invite them to the trial. And in fact, for a lot of these issues that we've listed, there are specialist treatments out there designed just for those sorts of problems. Whether or not they're easily accessible is a different issue.
Yeah, yeah.
So when we look at who we invite into the trial, these problems, things like pain, functional seizures, fatigue, and things like anxiety and depression are really common in the patients that are in the trial,
Okay.
And a lot of the patients rate those problems that they experience as quite severe, but they also tell us, and the clinician, the neurologist who sees them also judges that they're not so severe that they can't do physiotherapy.
Mm. Yeah.
So in practice, this is a group that often they don't have specialist treatments like the people with chronic pain do. And so what we're hoping to offer is a treatment that might be useful for them.
Yeah.
And when we sort of take out the people that we think are suitable for a standalone physiotherapy trial, it seems to be around about 30%. So your question about generalizability, how many people are likely to benefit from the treatment as it's described, perhaps it's sort of targeted to 30% of people.
Okay.
And the remaining 70%, they need a different sort of treatment.
Okay.
And it speaks to the issue about FND that a one-size-fits-all approach doesn't work. Each individual needs to be looked at and have a treatment sort of plan in place that's specific to them.
Yeah, yeah, that really holistic approach.
Yeah, exactly. So it's sort of it is a limitation, but I think another point to make is the sort of the things that we're describing, and if we are lucky enough to see that there is evidence for this type of approach, it might still be generalizable to the people that we've excluded. But what I think it means that they might need it done in a different way. So maybe they need it done less intensively, and it still might be helpful to accommodate for things like significant pain and fatigue.
Yeah.
Or maybe it should be done in conjunction with other treatments.
Okay.
But of course, that's another study, and
Yeah.
it's sort of this slow accumulation of knowledge that happens in clinical research.
Yeah, yeah, of course. All right. So what we often hear in Australia from different doctors is you need to retrain your brain. And many people don't know what that means. They're just told, I have to retrain my brain. I don't know what to do. What does that mean for a physiotherapist? How does a physiotherapist help a person retrain their brain, relearn how to move, relearn how to walk?
It's probably a very complex thing, and I'm sure we'll find out more and more about what that actually means. It's a really deep question. But very simply to me, the idea is for physiotherapy is that we're trying to help correct someone's movement. And then what we want them to do is to use that correct movement over and over again with repetition all the time throughout the day to reinforce that motor program in the brain so it becomes stronger and then more easy for that motor program to become initiated.
Okay, so
And hopefully,
is that when if you see a person using an incorrect movement, that person stops and might rest or do the movement?
100%. Exactly right. So when people have sort of unwanted movement patterns, we want to try and minimize that reinforcement of that movement pattern so that motor program doesn't become strengthened in the brain. You can't overdo it. It's okay not to work and move perfectly all the time, but the idea is that slowly the balance changes. So you get more of the good movement over time and slowly less of the unwanted movement over time.
Yeah.
And the idea really is that it's backed up with this sort of neuroscience concept of neuroplasticity. So that's the sort of connections in the brain, the neurons change and they make stronger connections. So there's actually a real change inside the brain that we're aiming to do with movement retraining. So any movement that's repeated and practiced over and over again should be underwritten or hardwired with neuroplastic changes. And this neuroplasticity happens in the brain all the time, and that's sort of the science underpinning what we're trying to do.
Yeah. And so my understanding of relearning how to move again is probably through my lived experience, and that would be, for instance, I had forgotten how to get out of a chair correctly. I was throwing myself backwards and then to the right because I had a very, like stroke-like symptoms. So I had a very weak left side. So, and I didn't know I was doing that. And I remember my first session with the physio, and she said, where would you like to start? And I said, I'd like to get out of a chair. I'm struggling to get out of a chair. And so she went through the movement and broke it down into about 6 or 7 small movements. and I had to do the 6 or 7 small movements just to get out of a chair. And I was really surprised, Glenn, that I'd forgotten that simple movement. But I had to keep practicing it, and I decided, rather than do it, say, 5 times a day, I decided to do it every time I got out of a chair. And we started out with that one small movement, and we, built it up to walking, moving side to side, etc. So it's kind of relearning how to move, and she actually was telling me how to move. It was the most bizarre experience, but it was, yeah.
And that's exactly what we would do. And for people who have problems with their legs, we pretty much always start by saying, let's get standing up and sitting down right first, and then things often follow from that. And there's lots of reasons why people start to stand up abnormally, or they sort of forget that movement, if you like. For some people, it could be shakiness of their limbs. For some people, it could be that they're unstable on their legs and they might be about to fall, so they need to hold on and do it slowly and build confidence to be able to do it. There are some people who can't feel their legs, they have numbness, so they don't necessarily know whether or not they're in the middle. And as in those sorts of cases, in all of these cases really, that's one of the reasons why we use a mirror. So watching their movement in the mirror, they can make these fine corrections and get that feedback. People know when their movement looks right, and they know often when it feels right. So getting people to tap back into those things as part of that retraining is really important.
Yeah, and then that also suggests not going beyond your capacity. So once you start to fatigue, I think sometimes your movements can go out, especially with walking. So I know at one point I was pushing myself too much and my walking just went completely out. So that was a barrier to me because I was trying to keep going. So
that balance is so important. So often people with this problem in life, that sort of want to push yourself and the sort of that work hard ethic gets you a lot of places in life. But actually sometimes in F&D, if you push yourself too hard, you slow down the process, because if you're pushing into, like you're saying, tiredness and then you keep going, it can start to reinforce unwanted movement patterns. So having the discipline to stop and rest and to do it slowly over time is really challenging.
Yeah, and I think that's
pacing.
really important. Yeah. All right. Now I've seen quite a bit around FND, around it being a problem of voluntary motor control, and that can get quite confusing for a number of people. I know one person said to me, "Oh, my doctor says I'm putting this on because it's a disorder of voluntary motor." So first of all, I'm wondering, what does voluntary motor function mean? And then this quote came from your paper around functional motor symptoms require, the patient's attention at a level without voluntary control. And then when the patient's attention is distracted, the movement disorder disappears or gets less. So I'm just wondering, what is this voluntary motor function and how is this attention-related movement used in treatment?
Yeah, it's a good question, and it's tricky to put it into words, but I'm going to do my best. Firstly, I'll deal with the quote that you've got there, that functional symptoms require the patient's attention or the awareness or the spotlight of their brain to be tuned into their body.
Okay.
And I've got for their symptoms to manifest, and I've got that at a level without voluntary control. Really what I meant by that is that the person isn't choosing to think about their body. They're not voluntarily paying attention to their body. This sort of focus on their body can happen at a level in the brain that they might not be aware of, or they might not necessarily be controlling. Does that make a bit of sense? So I'm not saying, so sometimes people can read that, or sometimes I can say to people, this is related to where your attention is. And people, it sometimes come across as me saying, or sounds like, oh, you're thinking about your body, therefore you're making it worse. But we're not really saying that at all. This sort of spotlight of the brain happens outside necessarily of our conscious control. We can't necessarily choose what our brain is attending to. So in the context of that quote, that's what I'm saying there. It's not the person's fault. It's not something they're doing to themselves. It's a pattern that their brain has gotten into. So in terms of how physiotherapy might be able to help with that, is what we're trying to do is we're trying to get movement to happen more automatically again. So when you think about how you should walk, and if you've got problems with walking now, how you walked before you had problems, you didn't have to think about it.
Yeah.
You don't say, now I'm going to step with my left foot, I'm going to bend my knee, I'm going to lift my ankle up so I don't trip over my foot, and then I'm going to put my foot down, and then I'm going to move my right foot. It just sort of happens. And it happens in different levels of the brain that we don't necessarily have conscious control over, and we can't necessarily choose to turn on and off. But when people have functional symptoms, functional movement disorder, that sort of level is where the problem is, and they need to sort of start to try to walk. They're using it's almost like their thinking part of the brain to initiate walking, and that in itself is part of the problem. So what a physiotherapist tries to do is to try to help initiate that automatic movement again. And the way they do that is they might set the person up in a way where to start a movement where the body can work more efficiently and automatically. So if we come back to what we were talking about before about standing up from a chair, we talked about some of those steps, and I'm sure some of those steps were to wiggle forward to the front of the seat, and to bring the shoulder forward, to lean forward into it, nose over toes. So those movements are sort of the way we do it. And when you do those movements, the body should sort of kick into the automatic movements. Your movements to sort of turn on the movements will kick in, and then the movements to extend back will kick in to stop you from falling forward. So this all has to sort of happen in a supportive, safe environment in physiotherapy. It's not something that you can necessarily just choose to do on your own. People could get better just by being told how to do it, they would.
Yeah.
But what we're trying to do is we're trying to help them with retraining, get these voluntary motor patterns to kick back in.
And then people often talk a lot about distraction. People are told to distract, and then that helps their movement. Is that because the attention's diverted into something else?
Yeah.
So you've got the automatic pattern kicking in.
Exactly. And if it was only so easy as just saying, just don't think about it, it would be great, because a self-paced distraction often isn't enough. So often you read suggestions like walk with your iPod in and listen to some music. But some people find that helpful actually, and it makes a difference. A lot of people it makes no difference to at all, because it's not really enough to divert the brain's focus of motor attention. Because most people can walk and listen to music at the same time. There is some sort of level of dual tasking going there, so it's not a big enough distraction, if you know what I mean. So the types of distraction we're looking at are two movements at once, where the brain has to really focus on one movement and let go of the other movement in order to do that one movement correctly. So the example is, sort of rubbing your tummy and tapping the top of your head. They're two things that are hard to do well at the same time. That's the kind of level of distraction we want to sort of do in physiotherapy. But obviously, we want to do something useful. We don't want people walking down the street rubbing their belly. Use it as a strategy to sort of get the normal movement again.
Yeah, and I think some people were saying they're getting the child to count backwards, like count backwards from 100 by 7, so that they're focused on something else, and that was helping to improve movement and symptoms.
If you're good at counting that, maybe that's helpful. And do you know what? When we sort of start physiotherapy, we might sort of try everything, and different types of distractions work for different people. So other things that we might get people to do is sort of tune into a different part of their body. If they're very aware of their feet, if they're really trying to step, we might sort of get them to think about their upper body, bringing their shoulder blades back. And then sometimes that's just enough. Or sometimes we might get them to sort of hold some weights in their hands and to try and get some arm swinging happening. With a lot of people, that just makes it very difficult. But some people can sort of tune into that sort of weight swing in it, and it might be just an additional little tool that they can have in their tool belt to help initiate some better walking.
Okay. Yeah, and I've had another person walked with a book on her head. So that helped
Very
with
nice.
walking. Yeah, yeah.
Yeah, I'm sure hopefully it sort of translates to when they leave the house, they can read the book at home. These sorts of things are great. And we do lots of funny things in physiotherapy. You know, there are no rules, try everything, have
Yeah.
a bit of fun with it. And
Mm,
then the idea is with the practice in the physio gym or at home, it
mm,
hopefully will start to translate so you can leave the house and
yeah.
have better movement.
Yeah,
But
and I
it's
think
a lot of work.
yeah, you mentioned the fun, and I think the fun part is also important because if it's becoming boring and repetitive and tiresome, people lose motivation. But when sort of games are incorporated or music or fun activities, I think it maintains motivation.
Completely. Like at the end of a session, sometimes we get up a YouTube video of a step-by-step, like after walking, doing lots of treadmill exercise. It's been quite an intense session. And then if we get a bit tired or we're having a bit of a break, towards the end of the session, you get up a YouTube video of a step-by-step how to moonwalk. We might spend the last 5 seconds doing a little bit of moonwalk practice. So walking
Yeah,
backwards, a bit of fun. You look like a bit of an idiot. But actually, it can sort of be a nice way to initiate some normal movement because your
yeah,
brain is sort of distracted into the novelty of the movement, and
yeah,
sometimes it's something to do, but also it sort of breaks up what can be quite an exhausting
yeah,
thing to do, and yeah, just make it a bit more enjoyable.
yeah, yeah. All right. So I notice it's a very intensive program, as we've said. It's 9 sessions over 3 weeks. The person's not doing home programs. What happens after that 3 weeks? Do people maintain that progress? Do they have to do ongoing physio after they finish the 3-week program? How do they maintain those benefits?
So, in terms of what happens, in a year's time, we'll look at the results and be able to report specifically what happens with our trial group. So we don't know at the moment, but we have done previous trials and smaller trials leading up to this one. And I get everyone's a bit different. There are some people who sort of like symptoms seem to resolve and they stay well and they're very lucky. And then there are some people who have a really great improvement. Sometimes they find that with time, the full benefit does start to reduce a little bit, but they're still a little bit better. Often that's related to if they've got other chronic problems that sort of wax and wane, their functional symptoms can wax and wane. And obviously there are some people who don't sort of improve with physiotherapy and maybe they need something different. So what was the second part of your question? It was about
And then,
how do I
yeah.
maintain it?
Yeah, so the next part is, when do we consider that treatment's not effective? I know some of us will go to physio every week and we just feel like we're doing the right thing by doing that. But if you're not getting better, is that useful? Should it be discontinued?
Yeah, if it's not helpful and it's not something that you enjoy, it's not helpful and you should stop it. So often, people are often put in a situation where they're sort of told you need to do this. And it might feel like if you don't, you're not helping yourself. But I think it needs to be thought about. If you're going and it's making you feel worse, it should be stopped. And then you need to think about, is there something else that I should be doing?
Yeah.
Or very often for some people, they just need to stop and allow their body to rest. And it can be tried again down the track if they're not getting better. Sometimes there are other things going on that can sort of make it not a great time to do very intensive treatment.
Yeah.
But in terms of sort of, I think ideally what we try and do, and often it's because there are budgetary limitations in terms of how much we can offer, but we sort of give people a block of treatment over a certain number of sessions or a certain number of weeks. And in that time that they're having treatment, the whole time they're learning the things that they need to be doing, just good habits with their movement every day that they need to be doing once they stop physio to continue to get better and stay better. So, in the ideal case, you don't sort of go and then do an hours of exercise every day. You sort of change your movement habits. So ideally, it shouldn't be something you're consciously having to think about or set aside time for. Instead, like we were saying before, every time you stand up, it's an opportunity to try and do a good stand and a good sit down. And as you walk through the day, you try and do some good physio walking, and hopefully that reinforces it over time, so it becomes automatic over time.
Okay.
So that's how
Yeah.
it works in the ideal situation.
Yeah, yeah, cool. And when people finish this 3-week program, you don't recommend that they continue any physio afterwards. It's just they go home and maintain those movement patterns.
Yeah. So what we would would like to do is just sort of say, we sort of set them up with a plan and sort of say, over the next 3 months, we want you to try and do this, and we do it together. We make a plan together, so people know what, they bring a lot of skills and experience from their own life to the treatment program. Together with the physio, they make a plan of what they will try and do, and then they go home and they put that plan into place, with the idea that they maintain any benefits that they've got, and maybe hopefully make some more gains. And then we review them at 3 months to say, how has that gone? And maybe we might tweak the plans, because inevitably people have some ups and downs along the way. And then they go on and they continue with that plan. And then they can be reviewed again. And for some people, that's sort of enough, and they don't necessarily need to come back for more physiotherapy. But of course, there are some people where they might need some more, or something different, or different types of treatment.
Yeah.
And I think we need to get away from the idea of thinking that you only have one shot of rehab, one shot of physiotherapy. People often have chronic symptoms that wax and wanes, and for every other condition, they might have several blocks of physiotherapy over the period of years. And I think that's completely reasonable if that's what they need.
Yeah. Yeah. Alrighty. So I think within this paper they talked about, not using assistive devices, for example, walkers, etc., in treatment. And I often see that a lot is, don't use your walker, don't use your wheelchair. Why is it so important that people don't use these aids in treatment?
Yeah, it's a complex thing to discuss, and it's not black and white. So it shouldn't be a case of all equipment's bad, you shouldn't use it. The reason why there's a lot of cautions about sort of using a walking stick or crutches, especially at the beginning, is that it changes the way we move. So as I've sort of spoken about before, just earlier, is that what we're trying to do is trying to initiate these normal automatic hardwired motor programs that are there. We're trying to tap into them with our physiotherapy and just throughout the day. But when somebody walks with a walking stick, it changes the way you walk, and it makes it less likely that you can tap into quick, normal automatic movement. Yeah. So in that early stage, potentially it can slow down your recovery. In most cases, it's probably not doing you any massive damage or danger, but it's just not ideal to start with a walking stick or a walking aid if you don't need it. Come back to that in a minute, but just in terms of other reasons why, if you can get away without using aids, you probably should, is that all aids, equipment, splints sort of come with a secondary cost. So for example, if you're walking with crutches and you're leaning heavily through those crutches to support yourself, people often end up with shoulder pain, hand pain, calluses, a bad back, particularly if you're leaning to one side of the stick. So that is a cost of the walking aid, and the effort of walking with the walking aids worse, the harder. It makes it harder to go upstairs. But of course, that cost needs to be balanced against the benefit of using an aid. So if you have a job that you need to get to and you can't sit at home and wait to get better, if you have a family to look after, if you live alone and you just need to get on with your life, sometimes you inevitably need to use an aid to make you safe, to stop you from falling over. So the cost and the benefit needs to be balanced. And then when you choose an aid, if you decide that you need one, and hopefully you will have good support to make that decision, then ideally you will look at ways to mitigate or limit the cost of that aid. So if you're walking with a stick to make you safe, are there times where you can walk without the stick to practice normal walking in a safe environment? Or if it's causing you shoulder pain, can you sort of learn how to take a little bit of less weight through it, or perhaps even change the hand that you use and still stay safe. So just this broader way of looking at it. There's another thing, like there's lots of things to think about with sticks. Is I sometimes worry that people are given just some equipment instead of getting good therapy. So here's a stick, here's a splint, you can walk now.
Yeah, they send you home from hospital.
Yeah, it's so maybe you need that stick to get out of hospital and get home, but then you should, I believe, have some support to get better, because some people are lucky and their symptoms resolve without treatment, but I think there are a group that have more complex problems that need support. So I think these are the reasons why there's a lot of caution over equipment. But I completely appreciate that sometimes those cautions are sort of overinterpreted, and maybe some people are denied equipment when perhaps they should have it.
Yeah.
So I understand there's two sides to the debate and it's complex, and hopefully in sort of when we've written about it or when we've given advice, we've sort of tried to give both sides of the debate, and that it needs to be a well thought through discussion.
Yeah. Well, I know I was sent home when I first came down with this condition 7 years ago. I was sent home on crutches, and as you mentioned, the pain, I wasn't strong enough to be able to carry my whole body weight on the crutches, and the amount of pain that I had in my body trying to do that, because I just couldn't carry myself around. Going to a wheelchair, it means that I can walk a little bit and not have to use that, but it allows me to, like, for example, I was housebound for 9 months and I couldn't do anything, but once I had a wheelchair, I could leave the house, get a job, travel around Australia, run forums. So it gave me that, it opened that up for me and allowed me to do things that I couldn't do when I could only walk about 2-3 meters. So.
And then I've got a different story. My physiotherapist was absolutely against aids, and she said to me I was allowed to use a walking stick at home and to get to physio, from the car to physio. However, when I was shopping, I was told, no, you cannot have a walker, Julie. And then I thought, well, I used to use a trolley, a shopping trolley. And so I thought, well, I'll still move normally because that's what I used to do before FND. So there was sort of devising different ways to get around that. But at times I was I'll be honest with you, I was in tears because of the pain, and your muscles are burning, and you just think to yourself, it would be so much easier if I could just use a walker because I want to do shopping, But I listened to my physiotherapist, and I was so glad she did do that, because my gait would have never really resolved properly by using, for me, this is my personal sort of story. I was very lucky to have a great physio. But yeah, as hard and all as it was, but I wasn't looking for work at the time. I was strictly in treatment, and that's, it's very, very, just treatment oriented. So I was very fortunate, and I used a stick after I finished my treatment only because of confidence, and then I threw it away. So
I think in retrospect, would you say that it was good advice, even though it was very tough?
Yes, it was very good advice, because I believe, for me personally, I would have used a walker, and thought in my mind, thinking as well, at least I can get around. I've got this walker, but I would have been moving incorrectly. My gait would have been out. I would have had a very weak leg. It wouldn't have resolved. So for me, but as I said, I had a great FND aware, educated physiotherapist. She was a neurological physiotherapist. So not a lot of people have that advantage. So, yeah.
Yeah, it sort of, again, speaks to that not everyone's the same, and the advice for one person isn't the right advice for another. So it's good to hear that, you know, important to recognize there are two different stories, and there's no right or wrong. It's what works for the individual.
Yeah, and again, it comes back to that holistic approach, very individual approach.
Yeah. Because I know people who wouldn't leave their house without a stick, and then if they don't leave the house, they're not going to get better. And so I often say, well, it's fine, take your stick. And sometimes they just carry the stick and they don't necessarily put it on the ground. And then when they're in a busy period where area where they know they're unsteady, maybe they're more likely to fall, they'll start to use it. And that's absolutely fine. And maybe sometimes those people, as they get more confident and stronger and better with their mobility, they'll do what you did, Julie, and throw it away.
Yes.
So there's no one way to do it.
No.
Yeah, and when I came down with symptoms, took me a very long time to get a diagnosis. So they put me on crutches. They said it was a stroke originally, then it was nothing. So I didn't even know what I was dealing with at that point in time, and trying to get used to the crutches, it just really caused me a lot of pain and really limited what I could do. Yeah.
And I was diagnosed really early in the piece by a neurologist who really wanted to treat me, who was really excited about FND, and I had no stigma. It was a totally different experience to Kate's. So it just goes to show you how different it can be for the individual. I had the ideal situation, you know, and Kate had a different experience. So we always find it fascinating, Kate and I.
That's the aspiration, that everyone will have that same experience that you've had, Julie. And
yes,
that's what all of this work and all of these discussions and interviews are all about, just to try and improve that. And it is happening slowly. 10 years ago, it was completely different to the way it is now. So it's frustratingly slow for the people who are faced with problems. But there is really positive change thanks to a lot of work that you guys are doing.
Right, and again, you know, this sort of does come down to this individual thing. Some people do respond really well to physio and treatment, others don't. So what would be your advice for people that are not responding well to treatment?
Yeah, I guess it's maybe you need to stop and have a look about maybe why you're not responding well. And it might be that we just don't know. For other people, it might be something like there's other problems with their health that are really stopping them from getting better. So I see a lot of people who have quite severe migraine. Maybe when they have a bad migraine, their weakness starts to get worse. And in that sort of situation, then treatment really for the migraine needs to be escalated. Same with things like chronic pain. So sometimes there are other problems that are preventing people from getting better, and so you need to have a good doctor who can help you look at things holistically.
So for people like that, you might stop treatment if it's not helping.
Well, certainly. So if treatment's not helping, or if it's making somebody worse, we'd stop and think, can we change it to make it more useful? Or actually, are we wasting each other's time, and is it just making people feel worse? Because failure of treatment feels awful for the patient and the clinician. Both of them feel really terrible about that situation. So if treatment is making people just feel bad, then sometimes the best thing to do is just sort of stop and rethink it. Is there something else available? Or would it be better just to have a break from treatment if you've had a long go and you're not sort of noticing any changes? In that sort of situations, for some people, the right thing to do is to get good support and set up so they can live their life, and then they can come back to it at a later date. People can where they might have sort of failed or not done well in the first attempt, things can improve the second attempt. It's also worth looking at, is this the right person for me to be working with? Are there other options? Going back and speaking to the F&D community, so organisations such as yours and the other ones, is a great way to get tips to find out about, are there other services available? Or I'm sure there's lots of great tips that you can share with each other about, this is what I do. Or just knowing that there are lots of other people in a similar situation as you in itself really helpful.
And then some people tend to have sort of episodic symptoms. So they might have one day, I know at one point I might lose the ability to walk, and then if I stayed in bed for a week, then my walking would come back. What do you do with people with these sort of variable episodic kind of symptoms?
I suppose together with the patient, the person, and maybe if I have other people of the multidisciplinary team available, we might sit with the patient to think about why those symptoms come and go. Or is there something that triggers them? Like I mentioned before, migraine, pain. For some people, other health conditions coming down with a cold or a flu is going to make their movement worse. Is it a very stressful time in their life, and is that making things a little bit worse? There can be multiple coexisting things all triggering symptoms, and if you can identify some things, or even something that may be related, try and sort of address those things. Of course, there are some people where it just seems to be the way, and maybe in those sorts of situations, if you can't find anything that seems to be triggering it, it might be a time just sort of thing. But often what we find, perhaps one of the most common things we see are people overdo it. So they've got busy lives, they're out working, they're exhausted by the week, and they're so tired. And as they get more exhausted, other symptoms start to come, their weakness starts to come, and maybe pain starts to come. And when their pain is worse, they might find their weakness is worse. And in those sorts of situations, helping somebody to sort of look at their life and saying, what can you do to cut down? How can we spread out this activity over a period of a week or a month? This is something occupational therapists are particularly helpful for, and it's a real skill that they have to sort of help people think about their problems within the wider context of their life. What can they change to make it better? Like, for example, for some people, using a wheelchair for an hour a day makes them much better for the rest of the week. So thinking about it in this sort of broad way is something that can be done.
Yeah, and that was where I got to, was once I got the wheelchair, I could actually live a meaningful life. Whereas before, I got to the point where I couldn't do anything because I just didn't have the strength to carry myself. All right. So someone that's newly diagnosed with treatment, what would be your advice to them? What should they look for? What should they consider before they start treatment and before they develop a treatment plan?
I think my advice is find a good supportive clinician or treating team as a first thing, and look for support. And some people are lucky to live in an area where there is a good service and experienced clinicians, and some people obviously don't have that. But I think find somebody, a clinician with experience and expertise in this area to support you is very valuable. And it sounds like that's something that really helped Julie. Sometimes you need to keep knocking. So a lot of people have the experience of being told, well, there's nothing wrong, we can't find anything on the scans, and it will just go away. And often it doesn't. So you need to go back and ask for help, find somebody who can direct you to some help. So looking for good support is really helpful. And arming yourself with knowledge is useful too. Some people I speak to don't like to read too much about their symptoms because it makes them feel frightened, or they might sort of find it hard to separate what information is relevant to them. But if you are interested, and I've seen on most people know the website neurosymptoms.org. That's a really good place to start. That's a website written by John Stone, who is one of the world's experts in this area. It also will link you to a lot of other really good resources that have been sort of looked at and checked and vetted, that you know you're going to get good information from that. So I think also what you can do is just sort of sometimes just try not to be too afraid of your symptoms and try and understand them. So people are obviously very aware when their movement is bad. And when their movement is good, people often don't want to think about it. They don't want to jinx it. They just sort of, hopefully they're better. But I don't know what you guys think. I'd be interested to know. But sometimes I think it's useful to sort of think about when things are good, why they're good, and can they make that situation happen more often. I think you guys probably would have better advice having lived through it than me. What would you say?
In terms of being newly diagnosed, being diagnosed in the first place is a really good place to start. A lot of people are struggling to get diagnosis, and I know that I found my diagnosis about 18 months later in my discharge hospital summary, which went to my GP. So I wasn't even told what it was, what it meant. I had to get onto the internet to find out what functional meant. So then trying to, make sense of the illness and then try and work out my own sort of treatment plan was complex. And that's one thing as an organisation I've been trying to change, so that people have sort of somewhere to go. We have, referral pathways so that people have somewhere to go where they can get knowledge, they can get information, they can get tips, they can see a clinician that actually understands FND. And that's one of the things that we see a lot in Australia. We're a very, very big country and people live in regional and remote areas, and there aren't clinicians in the town. There aren't OTs and physios and neurologists that are FND aware, or even that they exist at all. So that makes it really hard for them. So for us, having that online community is really important, sharing that knowledge, sharing the information, providing that support, and helping people to access care if they can has been really important.
And what is
knowledge?
Yeah. Well, I just wanted to make a comment on what you're saying about sort of Australia being a big country and the remote communities is a particular challenge for Australia, but more and more hospitals and specialist centres using telemedicine. So if that's available, that's really helpful. And there's a lovely study from Italy that showed it was really useful for people with functional movement disorders, and it involved physiotherapy, this study. And often what we try and do is we see a lot of community physiotherapists who are excellent physiotherapists. Maybe they haven't seen a lot of FND because that's not where the bulk of their work is. And sometimes just with a little bit of support from a specialist centre, they do fantastically good jobs, just as specialists do. Just sort of advice of saying, this is what the diagnosis is, this is the approach we do. Contact us if you have any questions. We think your input would be helpful. Sometimes that sort of permission and encouragement is all a community therapist, remote centre would need. And I think that's something that might be overlooked. Often the most important thing is you've got a therapist who's interested in trying to help
and willing to learn.
They will learn. These are people that they have the core skills. And the most important thing is that you feel like you can work with them.
All right. So a while back now, back in 2014, you published the consensus recommendations of physiotherapy for functional motor disorders. Given that's now almost 6 years ago, and we've had a lot of new research about FND come out in those 6 years, I'm just wondering if anything might have changed in those recommendations.
Really good question. I suppose I hope eventually things will change, because that means that the evidence and the science has moved forward. But regarding these recommendations, I think they're quite general. So there's nothing that we'd specifically take back at this stage. But maybe in the future we might be able to be a bit more specific to say where we've listed lots of different things that may work, and some things that we think probably aren't very helpful is sort of the way we wrote those programs, rather than listing a whole lot of general things, what we might then soon be able to say is, this of these things, this and this have the most evidence.
Yeah.
Or if the problem is this, try this as a first line and then maybe try some of these other things.
Yeah.
So at the moment, the evidence hasn't moved on enough to change the recommendations specifically. But maybe in the next few years, this is sort of a recommendation. The aim, hopefully soon, we'll be able to write an evidence-based sort of guideline for treatment. So sort of have that scientific data to back up. This is what helps most people.
Yeah.
But too soon at the moment. Yeah.
Okay. Yeah. So we wait the outcomes of your trial.
Hopefully that'll give us some evidence that helping people with specific treatment is the way forward. So fingers crossed.
Yeah.
But I think
to that.
Yeah.
Cool. Alrighty. Well, just thank you so much for your time and your insight. It's just so important and really important to share this, across the country and across the globe. So really thank you for your expertise and sharing your knowledge with us.
Absolute pleasure. Thanks for speaking to me. Thank you, you guys, for the work that you do, because things like the research that we've had funded would never have been funded without the community support, saying to the research bodies, yes, please fund this research. So this collaboration between charities and research is what really has been driving this change.
Yeah.
Thank you very much.
Yeah, that's okay.
Thank you.
Yeah, we'll talk again. Okay, well, thanks so much. Okay.
Okay.
Bye.
Thank you, Glenn.
Bye.